coming for this interactive session on 3D and strain. So one of the important the question which is often asked in echocardiography is how is the LV function, or in particular, how is the what is the ejection fraction? That is one of the questions which is often asked. Okay, so we'll go by go one by one. So okay, so we are seeing the long axis view. We are running the M mode echocardiogram. One of the things which we have been doing is doing the say measurements from the M mode echocardiogram. So they have not recorded actually the M mode from the 2D. We can have an anatomical M mode like this. Here we can measure the say diastolic volume, diastolic diameter. It will be diastolic diameter we can measure from the inside of the interventricular septum to the inside of the left ventricular posterior wall. That will be the diastolic diameter. From that, usually we use the cube formula for getting the volume. Similarly, during systole, we can get the diameter and get the cube formula. So from that, we used to calculate the stroke volume and then the ejection fraction. That is one of the oldest methods which we have been doing. After that came the two-dimensional echocardiographic method. For example, if you have this 2D picture, so here we can go frame by frame. Say usually the diastolic frame is over the R-way. This is the end diastolic frame. From here, we can do the volumes. Say this is, we mark the endocardium from one annulus, the septal annulus, then mark the endocardium like this. Now you get the left ventricular diastolic volume. So this is the diastolic volume 162 ml by the area length method and 159 by the Simpson method. Okay. Then we go to the systolic frame. Systolic frame is actually we have to just go in systole like this. Now the mitral valve starts opening. The frame before the mitral valve opens is the end systolic frame. So that you have to roll it and then go frame by frame and then find out the thing. And then find out the end diastolic frame. So here we have to do the systolic volume. We'll do it actually. Here the endocardium, the lateral wall, the endocardium is not very clear, but we'll take it like this. So the end systolic volume is 131 and the ejection fraction comes to 20%. So this is the two-dimensional echocardiographic method by using the say area length method or the method of disc, otherwise called the modified Simpson method. So usually we have to use not to use the single plane, you have to use the biplane. You have to use the apical two-chamber view and apical four-chamber view. In both the views, you have to do the say by method and then take the average of the two and calculate the diastolic volume and the systolic volume. So this is the second method. The third one is the three-dimensional echocardiographic method. The third one is the three-dimensional echocardiographic method. For this, we have to use the volume probe. This is the volume probe. So by using the volume probe, first you have to get the apical four-chamber view correctly. Then by using the volume probe, you can go to a X-plane or a triplane or even a multiplane. How do you get multiplane? Okay. This is the triplane viewing, multiplane. Right. Okay, good. So this is the multiplane viewing. So when you're doing the three-dimensional echocardiographic acquisition, first get the apical four-chamber view, then go to the multiplane view. See, in multiplane view, you can find out in multiplane view, you can see the from here to here, there are 9 cross-sectional pictures you can see. You can find out whether the left ventricle is included in the picture. So here you can see near the apex, near the papillary muscle. Here actually is the papillary muscle. Here you can see anterior mitral leaflet. Here you can see both the mitral leaflets. So you have to check whether the entire LV is going to be captured. Then switch over to the apical four-chamber view. To the three-dimensional echocardiogram. In three-dimensional echocardiogram, usually we use the 4-beat acquisition or 3-beat acquisition. With the single beat acquisition, usually the frame rate will be low or the volume rate will be low. To increase the volume rate, you have to use at least a 4-beat acquisition. Ask the patient to hold the breath during expiration and take a 4-beat acquisition so that there won't be any stitch artifact. You can see this picture is, there are no stitch artifacts in this picture. And the volume rate, you can see the frame rate is 29. It is a good frame rate. So those are the things you have to check. So first thing is get the apical four-chamber view, go to the multi-slice and see whether the entire left ventricle is being captured. Then go to the three-dimensional echocardiogram and get the multi-beat acquisition of the entire heart. This actually a section of the thing. If you want, you can see the pyramidal. This is the entire pyramid of pyramid which contains the entire heart. This you can cut it in whichever way you want. You can cut and remove the anterior portion alone. No. You can, here you have removed the anterior portion, anterior half of the say data. So we are looking something like similar to the four-chamber view. So this we can obtain from the entire data set, complete data set. The only thing is again always check whether the entire data, say entire left ventricle is there in the data set. Sometimes when the ventricle is very much dilated, some of the some of the balls may not be captured in the three-dimensional echocardiographic data. So to include that, you should see to that everything is included. So usually they use the 80 degrees capture. We can increase the width to 90 degrees if you want to include the entire left ventricle. Even up to 110 degrees, we can increase the angle to say acquire the say ventricle if it is very much dilated and all that. The only thing is if you capture with an 80 degrees, the frame rate will be higher. With 90 degrees, the frame rate is going to be a little lower, whereas with 110 degrees, it will be much lower. So the frame rate depends upon the angle of acquisition. So 80, 90 and 110 you can obtain. So from this data set, we can obtain the say left ventricular volume by three-dimensional echocardiography. First is we have to go to the menu and then select volume and select 4D auto LVQ. So this is the 4D auto LVQ. The machine itself will give you suggestions to improve the endocardial delineation, etc. So if you press the 4D LVQ, then you get a section of the 4-chamber, 2-chamber and 3-chamber, and there is a short axis section. You can clearly see. So now say you can see this line is along the long axis of the left ventricle in the apical four-chamber view. Here again the alignment is very good. Here again the alignment is very good. So now we have to mark the, you can select this frame and then you have to mark the apex and the middle of the mitral annulus. So these two, if you give, then it has actually drawn a volume curve, so which includes the entire LV volume. Here if you see here, it is not captured properly, so you can correct it if you want. Now I have corrected it. So now the apical four-chamber view, you can check the endocardium is correctly marked. And then in this view also it is correctly marked, and this view also correctly marked. And if you want, you can actually go frame by frame. Right. like this, you can rotate and see whether the endocardium is correctly captured in all the other views. So instead of the 3 views, so we can go to intermediate views, apical 4 chamber, 2 chamber and 3 chamber. All the other frame regions also you can check up like this by rotating and see whether the endocardium is correctly captured in the volume. So now we are satisfied with this volume, then we'll approve this one and then go to end systolic volume. So now the machine has selected the end systolic volume. So now you have to measure, you have to give the apex and then middle of the mitral annulus like this. Here it has actually gone out, little gone out. We'll bring it inside. I think it's okay. Here it is little inside. So if you want to make corrections, you can make the corrections and then see whether the endocardium is correctly delineated or not. So now the end diastolic volume is, end systolic volume is captured. So you can see here, see the end diastolic volume is 156, end systolic volume is 127. The ejection fraction comes to about 18. So what we got by 2-dimensional echocardiogram, it was about 20. By 3D, it is 18. Then we can go to the volume waveform. This is the left ventricular volume cost, which you can obtain from the 3-dimensional echocardiogram. The frame rate is about 29 frames, 29 volumes per second actually. So you can see the movement is smooth and you got the entire left ventricle as a cast, and this method is much more accurate than the 2-dimensional echocardiographic method. Why it is accurate? One is left ventricular apex is always captured in the 3-dimensional echocardiogram, because in the 2-dimensional echocardiogram you tend to foreshorten and the left ventricular apex is not often captured in the 2-dimensional echocardiogram. The other one is in the 2-dimensional echocardiogram we use a mathematical formula like a Simpson formula or some other formula. Whereas in this picture we don't use any formula. We use what is called volume cells, the number of volume cells which are present in this cast. From this, the volume is directly measured. So because of that, the volume which is measured by the 3-dimensional echocardiogram is much more accurate than the one which is obtained by the 2-dimensional echocardiogram. 2-dimensional echocardiogram usually slightly underestimates the volume, whereas the 3-dimensional echocardiogram, the volume is better. So this 3-dimensional echocardiographic volume has been compared with the MRI volumes. The MRI volumes, and it has been found that the correlation is excellent with the MRI volume data. Again, there is a minimal underestimation by the 3-dimensional echocardiogram. The MRI volumes are slightly larger than the 3-dimensional echocardiogram, but the correlation is to a certain extent, it is very good. And whenever you have in your institution a 3-dimensional echocardiographic equipment, always use the 3-dimensional echocardiogram for calculating, for obtaining the volumes, diastolic volume, systolic volume, and the ejection fraction. So you saw that once you get a good 2-dimensional echocardiogram and a good 3-dimensional echocardiographic data set, the measurement of the volume is accurate. So the accuracy depends upon the clarity of the picture, the 2-dimensional picture and the 3-dimensional picture. So the endocardium should be clearly visualized. Then only your data is, the volumes and etc. will be good. There will be a few patients, about 10 to 20% of the patients in whom the 2-dimensional echocardiography may not be good. You cannot improve it by doing a 3-dimensional echocardiographic picture. If your 2-dimensional echocardiogram is bad, if your 2-dimensional data set is bad, your 3-dimensional data set is also going to be not correct. So that you have to understand. Any questions on these 3-dimensional echocardiographic volumes of the left ventricle? We'll next go on to the 3-dimensional echocardiographic measurement of the RV. So when you are going to the LV, you saw that the left ventricular apex was there in the center. Here we are more bothered about the right ventricle. So this is a RV focused view, including the right atrium and the right ventricle. This is an RV focused view which you have to obtain in the by when you want to do the right ventricular volumes. So here again you can check up whether by flexi slice. Here again you can check up whether the entire right ventricle is there as a semicircular space like this. Here again, here you can get it. This is the inflow tract, and you have to see whether the outflow tract, this is the outflow tract which is included. So you have to see whether the inflow tract, right ventricular apex, and the right ventricular outflow tract all are captured in the three-dimensional echocardiographic data set. So once you capture the data set, then doing the volume is not going to be so difficult. The only thing is you have to spend some time, get the RV focused view like this, and then go to the multi-slice view like this, and then see whether you are capturing the entire right ventricle in the data set. So then you go to the acquisition and then acquire the RV in 4 beats. Then only your volume rate will be high. Here the volume rate you can see it is 21. So we have acquired the data set. Then we will go ahead with measurement of the right ventricular volumes in diastole and systole. So again we have to go to the measurement. Instead of LVQ, you select the RVQ, right ventricular quantification. First thing is you have to mark the tricuspid valve center, tricuspid annulus and tricuspid valve center, and then the long axis. You have to measure the long axis, and this line should go through the tip of the right ventricular apex. So that is the most important one. Then all the other things are getting aligned automatically. Then you have to select the points. This one is prompting you itself. You can see it asks you to mark the free wall. Only thing, this is the attachment of the tricuspid leaflet. You go a little into the RV and then mark it like this. Then this is septal. Then this is right ventricular apex. Then here, this is the LV RV posterior. So this is the left ventricle, this is the right ventricle, this is anterior and this is posterior. So you have to mark out the posterior one. Then the anterior. Actually, the anterior wall is not clearly seen, but we will mark it out like this. And then the RV free wall. So now it has marked the diastolic volume. Here you can see there is some, we'll accept this one.
I've got one question here, because what happens is that when you look at the RV wall in this, especially in the RV focus view, you have actually a sort of a reverberation artifact from the top, and the RV wall is outside of it. So I'm not sure if this is the same thing. Actually, this is the same problem here. Let me show you this. See here, for example, if you are looking at this RV wall here, this sometimes this could be an artifact, and this is the RV wall behind. See, this happens many times, especially when you are doing strain. You have to be very careful because you can get an artifact from the top which mimics RV free wall when the RV free wall is behind it. So that's something you have to be very careful when you do a 2D examination for strain as well as for 3D examination. See, for example, here, what is this wall here? This is RV wall, and this may be an artifact. So it could really be sort of the both may be RV wall, but many times I would not go for this, I'd go for that one. So I'll angle my transducer in such a way that I'm getting the RV wall and not this artifact. Okay, that's the important thing to remember here. That's one point I wanted to make.
This okay.
Yeah, this is something happens,
It depends upon your data set. You have to acquire it properly without any reverberation and all that.
Because it's very easy to mistake an artifact which mimics RV free wall for RV free wall, which is outside it. Just like I showed you here. Okay. Sorry. How to avoid it? No, you don't avoid it. You just go. Don't let them trace this one. Let them trace this one rather than that one. You cannot avoid it, but you don't trace that one. Trace the other one behind it. That's all.
Here again, the anterior wall is not clear. So here that's the problem. This you can see this anterior wall is not clearly made out. So you get some indentation or something like that. That is not correctly traced. But I'm just telling you the methodology only. See,
Yeah, right.
this actually is a methodology workshop. Say how
Just
to get it. Okay.
Yeah, that's
So
very important.
once
Yeah.
you get a good data set, then with say marking of a few points, you can get RV cast or a LV cast or an LA cast. So this is the methodology. So, but you can see once you do for say 10, 50 cases, then you will become much more competent. I am also not doing it regularly.
Yeah.
So yeah, actually, that's why I might I may
Check.
be tracing some of the things wrongly. So once you start doing it regularly in each patient in your case, say in your lab, then your say methodology improves, your endocardial delineation improves, your marking of the points also improve, and you get reliable right ventricular volume.
Learning curve. You would say that learning curve. Yeah?
Yes, that is a training curve. Yes.
No,
Yes.
So if I can tell you how to avoid that, the data set, I mean, Dr. Allegation is trying his best. So this is the sector and our focus is on the RV. See, we are losing a lot of data here. We don't want right atrium, we don't want all this structure. So depth, if you can decrease it, make the whole RV occupying almost around 70% of the whole sector, then you can't start appreciating the whole delineation. Yeah. So what are the tips for getting a good RV focused view? So, yeah, so you would like to answer that?
Yes. See, usually you keep the transducer over the apex, a little inside the apex to get the say LV views, four chamber view. So for the RV, you go little lateral to the LV from the apex position. You go laterally and image. You will get this curved RV view, focused view. So for each structure, we have to do, if you want to do volumes and strain, you have to do it in a focused view. So for LV focused view, in which the apex is clearly made out in the 4-chamber, 2-chamber and 3-chamber. For left atrium,
Now the artifact is very clear. See, very clear artifact now here. So this is the RV wall and not this one. And many times the computer will pick up that wall. So that's one thing. Now you have to remember that RV is like an envelope. It has got the septum and RV free wall. And part of the RV free wall, which lies over liver, is the inferior, you can say inferior part of the RV free wall. So RV is like an envelope actually. One thing remember. And the septum, of course, belongs to both ventricles. But with some newer ways of looking at it, the right side of the septum belongs to the right ventricle, the left side belongs to the left ventricle. So that way we can also look at it. Yeah. Okay.
The ideal
Yeah.
method
So this
to
is
look
something
at
which
the
is
RV
very
view.
very easy to make this mistake. And if you make this mistake, your values of strain and everything are going to be wrong. That's why I wanted to point this out.
The method is first, as Professor Allegation said, apical 4-chamber view. First, you go to the apex area, then go laterally, more lateral, one space laterally, then twist the probe marker first towards the right shoulder, then this way towards the right shoulder, then go to the liver, towards the liver. Then in between you will get this RV focused view. How to get whether this focused view is correct or not? LV apex should be at the top of the sector, LV apex, and the entire interatrial septum and interventricular septum should be in the oblique position, so that the maximum RV volume and volume will be visualized. So the 3 steps. The one more advantage is when we focus the RV focused view, when we put pulse Doppler TAPC or this tissue Doppler angle, this will be less than 20 degrees when you do it in the RV focused view. In the apical 4-chamber view, when you put the tissue Doppler angle, sometimes it may be more than 20 degrees. If you get more than 20 degrees, your values will be wrong. RV focused view, your tissue Doppler angle will be less than 20, your results will be robust.
Allegation, you said that you you shift the transducer from the apex laterally.
Certainly. Yes.
How is that? If you look at the anatomy, the RV is on the right side of LV. So how is that shifting laterally becomes more clear for RV delineation?
Are we
Twisted towards the right liver. Sir.
We have to do it.
Marker should be twisted towards the liver.
He's right, sir. He's right. So what do we go here and then twist
Then
it?
twist
Twist
it
it.
towards the liver.
So you have to
Anteriorly.
turn it.
Anteriorly.
While doing that, you can
Or else you can have a
mistakes. Commonly,
take the transition and show. Or else you can have a cut here
Patient
and you go
is
down.
not
That is the best.
if you go medially, then it is an RV
then
modified view.
twist towards the liver. While doing that, you will do two mistakes commonly. Commonest mistake is you expose the aorta and aortic valve. That means your probe is anterior. When you twist it posteriorly, coronary sinus will come. Capturing this RV focused view, either aortic valve and aorta should not be opened, coronary sinus should not be opened, only the intra-atrial septum and interventricular septum should be visible. That means you are rightly pacing and positioning the probe.
நீங்க right hand use பண்ணீங்களா? இது பண்ணு. அது வச்சுட்டாங்க. நானும் விட்டுட்டேன் பேசாம. பண்றீங்களா? Okay.
When we studied echocardiography,
Focus view only. நீங்க
it
பண்ணீங்களா?
was always taught
Focus
that
view, right hand.
you should always look at the
I am
anatomy.
used to left hand. That's what I am asking him to do.
Again, when we were teaching students, we always stress that anatomy is the most important information that you should have before you do echocardiography. So RV is medial to LV, and then you are saying now you go laterally.
இருக்கு ஜெல்லி இல்லாம இருக்கு. வச்சுக்கோ. இவரு நம்மள மாதிரி தான் பண்றாரு ஹெல்த்ல.
சார் ரைட் சைடு பார்க்கணும் இந்த சைடு சார் லெஃப்ட் சைடு பார்க்கணும் அந்த
ரைட் ரைட் ரைட்.
The first step is good to the basic fundamental.
கிளினிக்ல பண்ற மாதிரி பண்றீங்க. கொஞ்சம் இதா பண்ணுங்க நல்லா.
இசிஜி கனெக்ட் பண்ணலாம்.
வேணாம் பரவாயில்ல விடு. நீங்க வியூ மட்டும் தான் காமிக்க சொல்றேன்.
So this is the classical apical fourth chamber, sir. You go medially, you get RV focused view. This is the olden day method.
This is the old method.
Old method. Now what you do is go laterally, then tilt it medially.
Correct.
Between these two views, when by going medially and laterally, what will be the difference, Amudan?
Sir, this is the latest AAC guidelines. You have to use only this view, sir.
I will tell you what is.
RV focused.
So what doctor he's telling is initially we were told to go medially, but the RV used to become like this. But once you go laterally, the septum becomes more straight, and you get the lateral margins very nice. So
And
the
another thing
angulation.
is, if you
This
Yes,
is
sir.
laterally. This is lateral.
and
This
sir,
is
one
laterally.
more point is if you tilt it anteriorly, you will get aorta. You will get aorta. This
So
should
Dr.
not come.
Amuthan is lateral now.
Now, if you tilt it posteriorly, you will have the coronary sinus. So both should be avoided while getting the RV focused apical fourth chamber view.
Correct. Now this is going
This
laterally.
is the RV focal.
Can you
focused.
decrease the depth, sir? Can you decrease the depth? Make it big. Decrease. Perfect. And it should occupy almost 70 to 80% of the depth of the whole of sector.
And Kiran
This-
is very bulky.
No, don't change the focus. Just decrease the depth. Frame rate should be around 50 to 70.
Only
That's
if you
fine.
go laterally, you can capture the RV inflow, apex, and also RV outflow.
Outflow. all the
Outflow.
thing, Yes.
If you go medially, RV outflow, it will be
Will be
difficult
gone.
to capture.
Will be
It's
gone.
difficult to capture. That's one of the things.
So
You
the
want to do
best
the
is if
3D
you,
again?
in the table, if you have a
Madam.
cut, then you can surely put your eye. Put your thing inside, the probe inside.